Good evening to everyone. If you would go ahead and place your name and your campus in the chat. If I lose connectivity, just hold on. I'm gonna log back in. That's what happened. I lost connectivity, so I had to change internet connection. But nevertheless, we are here. Good evening to everyone. Go ahead and place your name and campus in the chat. We'll give you a little time to do that. Check your screen name as well. Ensure that it matches how it appears on the roster. Good evening again. If you would go ahead and place your name and campus in the chat. Check your screen name. Ensure that it matches how it appears on the roster. In the event that I lose connectivity again, just stay there. I'll just try logging in on a different device. And hopefully it won't happen again. But if it does, you never know about this connectivity. All right. So as always, these sessions are recorded and they are viewed by the attendance administrators. In the event that you can't be on the camera and you have something going on, just go ahead and log off and just send an email with the issue, and then we will just move forward with that. In the event that you're away from the camera for any reason, please take time to send a message to myself as why you're not on camera. Don't send a message out to everyone. All right. So welcome to this is our official last week of new content. So looking at share my screen here. Let's look at our modules. So remember, if you are taking more than one class, usually week 9 and 10, if you're taking more than one, sometimes, not all the times, the exams for exam 3 usually falls at that during that same week. So just keep that in mind so that you can, divide your time up equally or however is needed so that you can ensure that you cover all the content. All right. So we are here in week 8. So the exam that we will have next week will cover week 7, which is, remember, this is how we are paying, how a patient, a person is paying for the healthcare. It's all about pay. How does that facility get reimbursed? We have that at the end of week 6, I asked you all about you creating a perfect system that address everything, all the moving parts for healthcare. And so, as we talked about, and as we'll continue to talk about this week, we've created all these resources, these different PPOs, Medicare, Medicaid, all these different resources to help people to receive the healthcare that they actually need. And it's financing is a huge piece of this exam. So week 7, we talked about financing. How do we pay? Economics and health policy, which we'll toggle back and go back over that as well. And then this week, we're looking at the theories. So the bulk of the information will come from, that financing part. So on next week, so for exam 3, you're only looking at week 7 and 8 of content. Week 9, of course, we have in the exam 3, and then after the exam, of course, we have to meet back. We will just start looking back at all of our content from week 1 up until week 9. Week 10, you will present your projects, and then again in week 10, we will, after that, we'll probably do it before. We'll probably save our projects toward the end. But nevertheless, we'll do the projects. You all will do your presentations. Remember the final product. Everyone turns in the final product. If I completed slide 1 and my two teammates completed slides 2 through 6. We all put that PowerPoint together and we turn in that everyone, all three of us turn that exact same PowerPoint, that final product. You do your submission through, turn it in, but you're turning the exact same product, all 6 slides. No matter if I only completed one side, whatever, however I contributed, we're still turning it all in that same final product. So then we will start, we will also week 10 look back at the content again because we know the HESI is that next week. Keep in mind, all HESIs are in week 11. For sure, by the end of week 10, probably more than so, the beginning of week 10, you will receive information from your campus deans regarding your HESIs. Now, keep in mind, it might not fall like that. If this class falls on Wednesday, your HESI might be on a Friday, it might be on a Monday. It is campus specific. So make sure you're following the guidelines for your campus. If we're all in here, we're from different campuses. And so if you hear one student saying, hey, we're taking our leadership HESI on Friday, make sure that that is correct for your campus. And then this isn't too late of a day, but if you all are taking classes that are a little bit later in the day, for example, 7 o'clock, 8 o'clock classes, we do have some late classes. HESIs are traditionally not given that late. So for sure, just keep a pen in week 11 because you may have to alter your schedule. So be thinking about work, family, and all the responsibilities that you have, so that you can make an informed decision when your campus dean send that information out regarding what your HESI week is going to look like. And then of course week 12. This is Wednesday. Now they'll give us guidance on this, but over the past couple of years, we usually campuses have been closing on a Wednesday by noonish. It may be different this year, but nevertheless, in the event if that happens, we will send out alternate times that we can meet. Week 12, we do encourage all students to attend their week 12 for all of your classes because you do attendance is still taken and is still submitted. In the event that you don't attend week 12, then that counts against you. So we don't meet that long. We usually just go over the statistics. We look at our data comparing to the national to see how we did. And, of course, we talk about, moving forward to the NCLEX. So we don't even meet half the class time. So, but we'll have more information on that. But just kind of let you know where we're at and where we actually are going. So unit exam 3 is next week. So we have week 7 and 8 content on unit exam 3. If you are going to have that exam proctor, be identifying your approved proctor that has to be approved by your campus dean. Formulated email that includes your campus dean, the approved proctor, myself, and Dean Brown in the email with the information, date and time. So in the event that you all have accommodations since the last time, make sure that you send that all to everyone so we'll know what what it is that we need to provide for you. All right. So I was trying to get this little wheel here rather than me just calling out the concepts. I was trying to make it a little bit more interactive. So we will. So get your pens and pencils out. You'll do some jot noting. We'll give you time to think it through, put it in writing. We'll use the chat as usual, and then we'll have you to come off mute and then verbally respond as we go on through tonight's content. So let's just toggle back and look at some of our concepts. I mean, I hope this wheel works. I've used a different wheel in the past. So hopefully this wheel will work. Let me see. Shuffle. And then try to make the wheel spin you out. Oh, click the spin. Is that what I need to do? Okay, let me just share it. I think this is what I need to do. All right, so get your papers and pencils out and get my little timer pulled up because I do want to give you time when we mention certain terms and as you read your questions, your questions on your exams. Certain things, when you see a term or you hear a term, things should stop popular. That file cabinet drawer should come open, so to speak. And everything you know about that concept should start formulating in your head. So let's back up to a test taking tip. So you read the question, and sometimes it's a scenario. There are some questions that ask you, to define something, and you just look and you select a definition. But most of the questions, you have to actually know what the concept is and be able to apply what you know the concept is in order to select the correct answer. So we have a scenario, and then, it gives you all this other information that's really not needed. So, you sift through that information that's not needed and make sure that when you read the question, that you're answering what the question is actually asking you. So there'll be a lot of things in the question. It may have Medicare, Medicaid, then the final question will be asking you about Medicare. There's just an example. So just make sure you're answering what the question is actually asking you. Okay, so let me spin the wheel here. So you got your paper out. I'm gonna do some jot noting, and then we're gonna share it in the chat here. So this one, let me share, and I've spun the wheel already. So we do have a term up. So on your paper, just jot down everything you know. Hold on one moment, y'all. Hold on. Well, I'm going to show you the wheel, and I'll give you the 3 minutes. So yes, if you have not placed your name and campus in the chat, please do so. The other thing is check your screen name. Let me show you the wheel, the concept. Then did I need to do something real quick? Okay, so I spin the wheel already. This is the concept that popped up. It was Medicare. So on your paper, we'll give you 2.5 minutes to jot down whatever it is that you think you know about Medicare. So I'm going to start the timer. And then I will stop sharing. And I need just about 2 minutes to do what I need to do. So you are jot noting everything that you think you know or recall about Medicare. Try not to look at your notes. Just try to go off of what you know. Okay, my little mouse is doing something, y'all. Medicare. And as you jot down what you know about it, we have 50 seconds left. Just be thinking about that information that you've written down. Try to apply it to your patient in room 201. The patient in room 201, we found out that they have Medicare. And then think about the different settings in which, Medicare would pay for services. Think about, would they pay for it at the urgent care? What about if they went to the drugstore? What about if they went to long-term care facility? To just try to, envisioning that will help you to apply what you know. So just come up with a little scenario here.
Do I need to go in room 1?
Yes, ma'am.
Okay.
All right, let's see what you got here. Let's see here. So anyone would like to give us a scenario that includes Medicare, your understanding of what Medicare is? Anyone want to do that? A scenario.
like when you say scenario, you want to like like in the sense of Medicare, you know how they pay sometimes they can pay like partial. Is that what you're saying?
So what do you have for the definition of Medicare? What do you have? What things did you jot note? And let's
I
put that in
don't
the
know.
form.
Oh, okay. What I got on this paper right here, because I can't find my other paper. So I got basically for older people with lower income, Affordable Care Act, and then they have some deductibles sometimes.
Okay.
I
So older
do.
people,
Oh,
add to that. Anyone, older people, be
Oh
more
yeah.
specific. Because I
Oh,
I
consider
put
myself as
them
an
on.
older
65
person,
or
but I
older.
no, you're not.
but
Oh, I'm not saying you old.
no,
I
that
think
was
because
that was a
you
hint.
said older, but it got to be
Oh, well, maybe like
65 or older.
65 or
65
Got
60
or
to
or
older.
be
older. Okay.
65 or older. Yes.
Oh, let me put that down then. So I won't call nobody old again. Let me
So
get that.
our scenario could be, hey, we were working in the clinic that day. The patient came in and says, hey, I didn't get my Medicare card. I was expecting my insurance card to come through mail. And as you're completing the health history, you see that the patient is, we'll just say, 63. So, what re-education would you give that person that's standing in front of you? You would say what? She's thinking she's waiting on her Medicare card. What would you say? She's
You
63.
have
I would just say,
65 or older to get Medicare. Medicare.
yeah, I would just say, unfortunately, you're not at the qualifying age yet, so we can try other accommodations for you. You won't be able to get Medicare until you're 65.
Okay, so that's an example of how you're applying what you know about the concept. So the concept was Medicare. So that's
Mhm.
usually how these test questions are. These are these next gen questions. And so you have to know what Medicare is, specifically not just the older person, but specifically that age 65 and older. But what if, let's add to the scenario. The patient stated, I have end stage renal disease. Now, what would you tell her then? And
She
she's
would
still
qualify
63.
for it.
That
Oh,
she could
she's 63,
qualify.
but that's one of the mitigating circumstances. End-stage renal disease and um
ALS.
yeah, ALS. So you would qualify for Medicare if you have those.
Got it. So that's how you take what you know about the disease, about the concept, and then you're applying it to the situation. That was good. So that's a whole NCLEX question.
I'm glad
So
y'all took
she
it
will be
65
able to
or older.
qualify, but she's qualifying because she is a qualifying chronic condition. But generally, Medicare is for those that are 65 and older. We take care of our elderly. And usually when you say elderly, they mean 65 and older. But because she has one of the qualifying conditions, it doesn't matter about the age. And there are not that many out there qualifying conditions that a person can qualify for Medicare. Okay.
Okay, so
All right. Mm-hmm.
I got a question in regards to Medicare Part A, B, C, and D. I just want to make sure I understand
Uh-uh.
it
Hold
right.
your question, Miss Pugh. Hold your question. It's on the wheel. It's on the wheel. It's on the wheel.
Oh,
Hold on.
okay.
Hold it.
I
Yeah,
do
it's
have
on
a
the wheel. I was trying to
question.
piece it all out. Any
Okay.
questions about Medicare? Just the main topic. Just
I
right now.
have one.
Uh-huh.
So was it at some point, was it 60? Because I thought it was 60 and older. So is the solid number now is 65 and older?
It's 65 and older.
Make sure I change it on my paper because I thought it was 60.
All right. Let me share
Thank you.
here. You're welcome. Let's spin the wheel again. Hold on. We're gonna get to A, B, C, and D. So that's on the wheel too. Let's see here. Let's see what's gonna come up next. Okay. Accountable care. Accountable care organization. So we will give you the same time. Do the same, do your jot noting. Let me find a little clock here. Okay. So just do your little jot noting. Pull out your notes, highlight, circle, whatever you remember about accountable care organizations. Remember, all of these things is how we are paying for the health services someone is receiving. It is the reimbursement that the facilities are going to get, but each little concept has a different little spin or focus thing that they focus on. Medicare focus on those that were 65 and older and those that had certain chronic diseases. What about accountable care organizations? The clock is ticking. Give you a little time here.
Oh,
Oh, God.
All right, so about 30 more seconds. Accountable care organizations. You're jot noting everything you have. I'm gonna actually stop sharing here. Accountable care organizations. So these are ways that we pay. This is way facilities get reimbursed. Each one of these concepts have a little thing that they kind of focus on. So what about these ACOs? We got 20 seconds. All right. Anyone want to tell us about ACO? Just give us what you have on your paper. You don't have to do a scenario to it. Okay. A group of doctors and hospitals came together to give coordinated care to their patients. All right. You can come off mute and tell me too.
It helps people
Like
get
a
healthcare insurance.
yeah, healthcare payment care type thing that's connected to Medicare, if I'm saying it right. I feel like it is.
Medicaid
I'm no
Accountable
To
care
expand.
organizations.
To expand Medicaid.
I thought it was Medicare. So it's not Medicare and private insurance?
So we're talking about accountable care organizations, not Affordable Care Act. We're talking about accountable care organizations. Okay, someone put quality. What else did you all put? Let's see, quality. You wrote overall care. Okay, so what is there? So all of these resources, Accountable Care Act, all of these, the J code. We're talking about all these are for the most part nonprofit organizations, but they're regulatory organizations or some type of regulatory entity. So accountable care organizations, they're more focused on unnecessary spending. Someone said quality and cost. So they look at that, the quality and cost, they look at reports. So they want facilities to send in, so the patients that have Medicare, they want the facilities that are receiving reimbursement for those patients. So for example, they go into the hospital, or they're going to the because we had a different parts. Hold on, Miss Pugh. Hold on. A, B. We got the different parts in A, B, C, and D. So the patient's being admitted to the hospital. ACOs, Accountable Care Organization, says, hey, we're going to reimburse you, but we want to see your data on the number of falls that you're having in the facility. We understood, our patient was there and you submitted charges for a fall. Now, while we understand, she was there for whatever reason she was there. So we want to see your data. So that's documentation is important anyways, but with accountable care organizations, the people that receive reimbursements for the Medicare, charges that they're submitting, they want to look at the reports. They want to see the number of staff that you have. They want to look at the number of urinary tract infections. They want to look at all of these things because that equals quality. They want to make sure that they're just not reimbursing you for unnecessary spending. So that's what that accountable. So it makes the facilities more accountable, so to speak, accountable care organizations. So we got that on accountable care organizations. It is where those providers, they come together and they're supposed to be, all of it's supposed to be high quality care, the best care that a client can receive. But ACOs, their goal was, hey, if we put this pressure or if we put this mandate where these facilities have to send in these reports, hopefully we'll improve outcomes, because who wants to send in reports where they had 100 patients and 100 patients end up falling, 100 patients ended up with the wrong surgery being done, 100 patients ended up with, staph infections and so forth and so forth. So that was the whole idea behind that accountable care organization. They put their little spin was decreasing spending while putting more emphasis on that quality of care that we are providing. All right, so let's spin the wheel again. Let's see what we got here. Share my screen here, and let's take that one out. Let's spin here. All right. All right. Ms. Pugh, Medicare Part A. I know you're going to answer this one for us. Medicare Part A. Go ahead. What were you trying to tell us?
Well, I was just wait, did you say Tanaja?
Yes.
Oh, okay. Well, I guess I was just gonna ask like because I work in a healthcare fair as a clinical coordinator, and today I had a patient.
Don't tell us where you work at. Don't say where you work.
Oh no, I'm not telling you where I work. I was gonna use
I
this.
just wanted to provide
Oh
the
yes, ma'am,
reminder.
the scenario. So it was like what was it? Oh my gosh, I'm trying to think of what it was. It was on my mind. I'd have forgotten it. Oh, it was like I forgot.
I messed your train of thought up. Okay. I just didn't want you to
We're
tell us.
on part A or part. Which one did you just spin it
We're
for?
on, let me go back to the wheel. I think we're on part A. So does your scenario match part A? It's part A.
Okay. Does Part A refers to hospice, hospital care,
Inpatient.
inpatient
Pay for
care.
stays and surgeries.
Inpatient care.
Okay, this was my patient was 68, and I think he had like retired and had Medicare. He fell, broke a hip or something like that, and went in the hospital for surgery and had to stay for a couple days. I didn't know, I didn't know Medicare get like it breaks it down. So like Medicare A was paying for the hospital stay and the surgery, and then B helped cover like the outpatient. I think it was like her outpatient services. Is that right?
I see heads going up and down. So
Okay, and
it's
then
spot
D.
on. So what your facility was doing so far is correct. Go ahead. Keep
Right.
going.
I don't remember anything about C, but I know for D because I was getting confused with the medication parts with prescriptions with D. So I'm still struggling on Medicaid D. But does that sound right? Because I was
Do
like,
we
man, I think
agree
I
that
looked
A
at
is
school.
inpatient? Do we agree,
Yeah.
you all? A is inpatient, B is outpatient, D is medications or drugs. Now, we haven't got to part C yet. So what does that C part comes from? It's optional.
That's Medicare Advantage.
Yeah.
Exactly. So the
So
person can also subscribe to that, but you automatically get A, B, and D. Go
right.
on, Miss Green. What were you telling us about Medicare Advantage?
So Medicare Advantage is either HMO or PPO. That covers like for your patient, everything was connected and bundled correctly. So because that patient fell, their Medicare A kicked in, which automatically linked in their outpatient, which automatically linked in their Medicare Part D. And if they refer connected right and put the right HBC codes and ICD codes, it will also cover their outpatient care as far as their doctor visits and any medical equipment that patient may need.
I heard her say, what entity oversees medical equipment? And we ain't got to on the wheel yet, but just come off mute and tell me what oversees medical equipment. Make sure that it's safe for us to use. What are those three letters?
The FDA.
FDA. So as people are saying things, you on, as you're reading things, certain things should be just popping up in your mind because these are the concepts. Of course, we have a scenario, but remember it's next gen, so that's good. Something else came up. Okay, so all of that information, Miss Green and Miss Pugh, went back to the nurse and the doctor doing what?
Making sure that they document the patient correctly, put the correct ICD codes and
Exactly.
HPC codes, so that way everything can be connected to that patient's Medicare. Because it'll
Had
be paid in
someone
one
not
bundle.
exactly. So have someone not taking the time to document, nurse or doctor, what was going, signs and symptoms, assessment findings, subjective, objective data, not taking the time to put the lab orders in, the radiology, all those things, then that would not have led to this patient getting all those different services that they were going to need to be paid for. And also the other piece of that hospital, the clinic, the doctor's office, and the pharmacist getting their monies, they're reimbursed. That was a beautiful scenario. Great, great, great. Let's spin the wheel again. Here we go. Here we go. Where's my wheel? And I'm checking out the chat too, y'all. So you all look in the chat as well. You all are sharing in the chat. So the more we go over it, the more it is going to be with us. So we're going to remove Medicare A. Let's spin it one more time. I don't know what this thing is doing. Okay, there we go. All righty. Okay, B, Medicare Part B. We kind of already talked about this. So just come on, just put in the chat real quick, everybody, what B takes care of. You can just do a one word or an example of that one word in the chat. So everyone, make sure you're submitting Medicare Part B. What does it take care of? Let me remove it out of there. And let's see what you're saying. B, you can just use a one word or one phrase or give us an example. All right, outpatient, great, great, great. Outpatient care, great. Let's keep it moving. So far, so good. And let's spin. All right, so I'm gonna put the timer on. You may need a little time to think about value-based purchasing program, but think about what words that you know that's in this scenario here. So let me find my little timer, value-based purchasing program, and do some jot noting.
I got a question, Dr. Ford.
I'm listening. Go ahead.
Oh, okay. So when you were talking about the ICD-10 code, so that's like if you were sending off urine or any type of labs, so that's why it's important to put the correct ICD-10 code in to make sure that it's billed through the right services.
That's correct. And what they do is they still go back to the documentation to make sure that that code, there's documentation to support why we put that code on there.
Okay, the reason why I ask because when I do it at my job and if you put the wrong ICD-10 code, it'll tell it, that they can't do it. So I was just wondering why. So that
Yeah,
makes
there's a whole different conversation about the ICD codes. First of all, you have the supporting documentation, and also you have to code to the highest degree, which that's not a conversation for here. So coding, you have to code to the highest degree. So based on it, once they look at that documentation, if that code that they submitted wasn't the highest degree of care and what was really going on with that patient, that means that they need another code, and it's a process to code. Is what
Yeah,
it
but I
is.
was just asking as far as like, is that why it wouldn't like kick in for that type of service? That's what I was asking.
So if the documentation is not there, and if the documentation is there and it does not support that code that they sent, they will ask for another code.
Ready?
Okay.
Yep.
So value-based purchasing. So got about 1 minute left. Value-based purchasing program. Remember, all these our lawmakers are they've come up with all these different programs, government. It helps to provide the best care for our patients. So here we go, value-based purchasing program. 35 more seconds. All righty, what do you have? On value-based, administered by CMS. Okay, value-based. What are they looking at?
Quality over quantity.
They're looking at quality over quantity. Okay.
And they're looking at the overall compliance of the hospital or the facility.
Uh-oh. So what is that? Give me a scenario. Give me an example where they will look at compliance.
As far as compliance.
Mhm.
Oh,
Safety.
that's a good question.
So safety. So falls come up again. Safety, the rates of infections. So if a patient was admitted for, let's just say they came in to have a colonoscopy, but they failed. And so of course, gonna take care of the person. They fail, may have broke their foot, knee, arm, leg, or something. So the hospital is gonna, of course, submit charges or ICD codes and all that stuff to get reimbursed. So what the value-based purchasing program, it looks at, it says, hey, this person was admitted for this. The person was admitted for a colonoscopy or admitted for something totally unrelated to that information that they're submitting a fee for. Person came in for this and now they falling. Person came in, they having surgery, same day surgery, and because they had surgery, they had to put in a urinary, they had to put in a Foley catheter. Now the hospital is submitting charges because this client is having to have surgery to fix a broken bone, or they may be having to take antibiotics because they ended up with a urinary tract infection. With the value-based purchasing system, they say, well, wait a minute, was there quality care given when this patient came in? Because what you're submitting charges for is unrelated to what they originally were there for. So why are we having to pay for this urinary tract infection, antibiotics, and why are we having to pay for surgery to fix his broken bone? This patient came in for something that's totally not related. They looked through the documentation because they've established these standards. And so what insurance companies and these what they decide, they make a decision. Hey, we're not going to pay for this. Yeah, we want you to take care of this patient, take care of their urinary tract infection, take care of that broken bone. But because the care, the value that you provided or did not provide for this patient is why they ended up with a urinary tract infection. It is not an automatic that because a person gets a Foley catheter inserted, that they should end up with a urinary tract infection. That is not the standard. So with the value-based program, they decide whether or not they're going to actually reimburse those facilities for those charges that they submitted related to that unrelated diagnosis that that patient ended up with. Now, if the patient has some other things going on and they can look at the documentation, there's a paper trail that says, hey, a person came in presenting with chest pain, but really, based on the test results and all this other stuff, they ended up, this is really what was going on. The patient reported they had fallen maybe a couple of days prior to coming, had a little pain in the leg or arm, but today they were presenting with chest pain. So that documentation will kind of provide support to say, hey, this person really probably did have this broken extremity, is in addition to why they really came in. But if the value-based program determines that the unrelated charges that are being submitted are unrelated and it's fault of that facility, meaning fault of the staff, if we break sterility, we know what we're supposed to do. If we're having a person's having surgery, we know that there's a timeout procedure. We should be submitting charges for surgery on an extremity that's not the reason why they actually came. We hear all the time wrong surgery sites, wrong patients, but facilities, they still submit those charges. Value-based says, hey, we're not going to pay for that. We want you to take care of the patient, but the facility has to absorb those costs, those charges. So they look at that quality over quantity, for reimbursement. And I'm just looking at what else you all put in the chat. Okay, value-based. So the UTI is a huge one. In the falls, people end up with broken bones and it's unrelated to why they actually were there. So that's where you get the unit-based teaching. You get the facility-wide teaching because we're going to talk about JCAHO here in a minute. When they come in and they look at the reports and everything, they say, well, and you can be on the team too. In addition to your regular tasks, they do have committees, QI committees, where they look at all these standards that's been set by these regulatory agencies. Falls is one of them. Medication errors is one of them. And if you're working on that committee, you go out and collect data within that facility to see are the processes, is the policy and procedure, is it correct? Or is it the staff that needs to be retaught, don't understand? Was it the electronic medical record? Did it have a glitch in it? So you have to kind of figure out why are people having so many urinary tract infections? Is it the equipment or is it our staff? Is it occurring on the same shift? They go back to who was clocked in. They track it back to who took care of the patient and all of that. Even with the staff infections, they ask the question. They do these surveys. Did you see the staff? Did you witness the staff washing their hands or using hand sanitizer? Did the staff speak? They introduced themselves. Did they ask you to identify who you were? They asked all these questions. All right, so let's spin the wheel again. Where's that wheel at? All right. Let me share the screen here so we can see what we got. All right. HMO versus PPO. So for this one, do some jot noting on both. I know we have PPO listed separately, but one is really, you can tell one is not the other. So on your paper, do jot noting for what an HMO provider is and a PPO provider. Okay, let me set my little timer. Move it. So what is a HMO provider versus a PPO provider? Set my timer here. Okay, so we're jot noting about HMOs and PPOs. All right, I'm seeing your responses in the chat here. All righty. So HMOs, they typically have more of a limited network. They have a certain set of providers. Okay. Doesn't mean you can't be referred though, but they have that HMOs have a more limited network of providers. And a referral is required to see a physician that's out of the network. So PPOs usually have a larger network and they don't require that referral for a specialist visit. So HMO, so like if, the Affordable Care Act, it, had the marketplace. So you can go in and shop around and decide which plan worked better for you. So we know with HMOs, because they had that limited, and this is, just something they came up with, that limited network of providers that require a referral. There were lower premiums and lower out-of-pocket costs. But the other part was it was less flexibility. So you just went in and you shopped around and you decided, and even now you decide which insurance plan that you really want, what's going to best fit you. If you're needing to see specialists to manage your disease process, then know that with that HMO, you're going to require that referral. And it's not an automatic. It has to be approved based on the documentation. And they have, they want a certain number of labs on, they want certain medications tried, and and so to speak, the patient failed on those medications because you have to kind of prove that it's necessary. So while the HMO have lower premiums and lower out-of-pocket costs, you're limited to the networks that are the providers that are in the network versus the PPOs. They have the larger network and it does not require a referral. So you can see, out of network doctors, but then the other piece of that is the costs are going to be higher. The costs are going to be a little bit higher. All right, so check what you had. On your paper and see if that match. All right, let's spin the wheel here. All righty. Okay. Affordable Care Act. So outright, just go ahead and come off mute and tell me, at least three of you out, tell me one thing that you remember or the Affordable Care Act allowed for or caused to become in existence. The Affordable Care Act. Remove it. So just come off mute. I need three of you out to tell me about the Affordable Care Act.
It is what is it? A healthcare law that was passed to make insurance like more affordable or something like that.
Exactly. And that's what, and so how did it do that? So she's giving us the leeway in. So it made it more affordable. So think about some things that it did.
Obamacare
Someone else.
was it?
Increase across the health insurance.
It's
Say that
Obamacare
again.
for
Say that
They
again.
got rid of lifetime thing was like lifetime illness something. I forgot the
It
word. It was like a
it
life
eliminated pre-existing if you have
that
pre-existing conditions, you could still have healthcare.
Okay.
And then Medicaid expansion, so it didn't vary so much from state to state.
Okay. So I heard you all say it eliminated those lifetime limits. So for example, if but prior to the Affordable Care Act, for example, if you had hypertension, all your care related to hypertension, if it exceeded, we'll just say $500, then that meant once your doctor or whomever submitted charges beyond $500, it fell back on the patient to pay for it. So it eliminated those lifetime limits. The other thing I heard you all say was it took away a patient being penalized for having a pre-existing condition. That same scenario, the person prior to getting that insurance had already had hypertension listed on their chart, that all the charges that were submitted for that diagnosis were out of pocket on the patient because it was listed as a pre-existing condition. So people were like penalized for trying to take care of themselves. And then I think I heard you. What else did I hear you all say? Those are the two main points that I heard. Or did you all say something else?
Didn't it make it more affordable also?
That's how it made it more affordable. Because think about it. If a person has hypertension and prior to the Affordable Care Act and they only gave you $500, that person's still living. 50, 60, 70, 80 years old, and they're still probably more than likely going to need hypertension care. But they only give you the $500. So prior to the Affordable Care Act, whatever all those costs were, the patient had to pay for it. The doctor can submit it all day long, but prior to the Affordable Care Act, they would not pay for it. So it made it more affordable. So doctors were getting reimbursed. Patients were not having to take out loans just to pay for their doctor bills. So yes, it made it more affordable. Eliminated that lifetime limit. What was the other thing? So the other thing I think I heard you all say was employers. So insurance is expensive. So employers get some type of discount or have a different rate. I won't say discount, they have a different rate. So the Affordable Care Act did allow for ask employers, hey, at least offer this to your employees. And I think it was a certain size, but that part is not important. But the thing about employers, at least offer it to the people that work for you so they can at least be able to subscribe to insurance at a lesser rate because insurance it costs, it's really expensive. So because employers were having that less rate or a discounted rate, people were more apt to subscribe to insurance because they were not paying $1,000 or $1,200 a month per month just to subscribe to have this service. That same coverage, because the employer offered it, may be $600 versus $1,200 out of pocket. So that saved that person a whole $600. Those are just some numbers I'm just throwing out there. All right, so let's spin the wheel again. Got the Affordable Care Act. Share. My little mouse is moving. So it's on PPO. So what do we say about HMO PPO? Go back to your notes on that. Someone come off mute and tell us what was HMO PPO versus PPO.
HMO has less
yeah.
less providers, you have to have a referral, PPO, more providers, maybe higher cost because they're out of network. I think that's how we explained it.
Yep, that was correct. HMOs are typically those you go to those doctors that are in network. Usually the premiums are less, but then you have to wait on that referral process, and then so the PPOs have more flexibility. You don't require that, but then those plans that are those insurance plans that you subscribe to that are PPO, they usually cost more. All right, let's spin the wheel again here. Okay, Medicare Part D. Someone I think already put it in the chat for us. And Ms. Pugh kind of already gave us a scenario. So what do we say Medicare Part D takes care of our what?
Prescriptions.
Our medications, our drugs, prescriptions. Okay, great. Good. Let's spin it again. We're moving right along here.
I have a question. This might be a dumb question. The
Mm-hmm.
different parts, the
Mm-hmm.
different parts of the Medicare. So is it like you can only have certain parts, or is it all collectively like a part of Medicare? Or do you just get approved for like different areas that are like specific to your needs?
Okay.
Does that make sense?
Yes, it does. Medicare is federally funded. So once you turn 65, you automatically are offered Medicare parts A, B, and D. C is optional.
Okay.
Mm-hmm.
Okay.
C, you can pay for it and subscribe to it. I'm trying to think, who was that helped us with the Part C part? Who was that helped me? Was it you, Miss Shanika? Who was it that told us about their patient? Miss Green. So yes, Green and Miss Pugh.
Tanaja.
Yes. What you say?
No, Tanaja had the scenario, and then I was helping with the explanation.
Got it. So you automatically 65 and older, federally funded. And if, we'll bring us all back up to speed here, if you have those qualifying conditions, which you named two, that matter about the age with those qualifying conditions. And then you automatically get AB. A is in, B is outpatient, D is medications, drugs, or prescriptions. C is optional. That person will have to pay and subscribe to that. And it does help pay for some medications as well. Just think about it. If a person has certain disease processes, medications. I don't know if you kind of looked at that whole thing that they give you when you go to the drugstore. They have like this fee, but then the amount that you pay, that other fee is probably 20 times more than what you would actually pay. So if a person has a chronic disease process that requires certain medications and also several different medications, it would be more affordable for them to subscribe to that Part C in addition to the D, because D is going to probably cover a good bulk of it, but still, usually someone that's 65 and older, they usually are that beautiful word. They usually are retired. They usually are. And so they probably have that fixed income. They can't pick up a shift here and there. So it would be more affordable for them to pay for that Part C to help them pay for those medications, especially if they're having to have several medications and medications that cost a very high amount. Okay, A is inpatient, B is outpatient, D is drugs and medications. You automatically get those. C is optional. All right, so we have Medicaid on the wheel. Medicaid. Let's do some jot notes. Let me give you your time. I have to set my little timer here. Okay, Medicaid. All right. Do some jot notes. Okay, I see in the chat. I'm seeing mostly it is specifically based on the person's income and low income. Those are the terms that I'm seeing there. You still have a little bit more time, and that is correct. And it is who funds it. So in your notes, did you write down where does the states get the money? Where do the money come from? I'm trying not to tell the answer. Where does the money come from for someone that has Medicaid?
Is
Because
it
nothing's
federal or
really
My
state?
taxes, ain't it? My taxes.
I heard someone say federal
Federal
and
and
from where?
state.
It comes
Federal
from
and
both.
state. It
State.
was
Federal
funded
and
by
state.
federal and state.
It's mostly state, but it has federal funding too.
Both state and federal. Okay. So it's income based, low income. Eligibility is based on the income and that financial need. Okay. It provides that health coverage for those that have that low income. All right. Let's spin the wheel. We got Medicaid. And let's see here. We have CHIP. What about CHIP? So do your jot noting on CHIP. And then we just have one more left. And on CHIP. And you can put your responses in the chat. We're talking about CHIP. Capital CHIP. And it does stand for something. You all tell us. See what you're putting in the chat. Got it. Miss Bell, Miss Asbury, they're spot on. Keep going, keep going. So if you make $1 over that required income that qualifies a person for Medicaid, that means that you do not qualify for Medicaid. And on the same hand, you may just make that $1 over. We just talked about how private insurances, they made, when they were created, it really made healthcare costs go even higher. I mean, really, healthcare costs skyrocketed because of private health insurance. So here it is. I made $1 over, don't qualify for Medicaid. Well, I don't have the money to pay for this private insurance, because if I do, that means I probably won't be able to pay for all the other things that my family needs. So what they did, they created CHIP. It's for the children up to the age of 19. And so it does not mean that the child does not get the preventative services. As a matter of fact, they do. They get the same services. The child checks, the preventative care, they actually can get the same services as with Medicaid. It's just CHIP is who pays for that. Because the way they wrote up Medicaid, they have that dollar amount. Don't qualify. So up to the age of 19, the Children's Health Insurance Program still it pays for the health care that the children will get for those parents that the income they make too much to qualify for Medicaid, but then not enough to also pay for that private insurance. All right, the last one was Medicare Part C. Anyone else want to give his last words on Part C before we go on our break? Part C.
So Part C, like she said, can be financially heavy on retired or people 65 and older. So a lot of times if they're compliant with certain programs, like an online cooking for whatever pre-existing condition they have, a lot of times they'll help pay for that HMO or PPO. But if you have savings, you can do a HMO or PMO at a discounted rate because you're 65 and older. Also, CVS and Walgreens have programs for C and D.
Okay. All right. So even though that person's having to subscribe and pay that premium out of pocket monthly, it still is more cost effective versus that person outright just paying for those services. All right. So let's stop here, and we're going to take our first break. So we'll see you back at 6:37. Remember, this recording still plays, so make sure you're on mute and turn your cameras off.
What
Did I
time
say
you say?
6:37? Wait a minute. That's only 2 minutes. I'm sorry. Let's return back at 5 would be 6:42. Thank you. I caught myself that time. 6:42. see. All right, here we go. Let's get it rolling here. All right, let's see here. So remember, accountable care organizations are groups of healthcare providers that coordinate that high quality. They want to make facilities accountable. They want to, and for the most part, all of these different resources look at, hey, is this unnecessary? You know, because they want to reduce the unnecessary spending because these businesses, these different organizations and resources are in business to make money. So they don't want to be, they want to take care of the people that subscribe to their services, but they don't want to be spending unnecessary money. And at the same time, you know, on the other hand, we don't want people, you know, getting urinary tract infections, you know, the value-based system, and that's not the standard. The standard is that we have a technique and, you know, we have, and it's an honor system. So if we break sterility, we know that what we're supposed to do. And we're going to talk more about evidence-based care here in just a few moments. I brought up about the breaking sterility. Back in the day, probably about 15 years ago, maybe even a little bit longer than that, prior to putting in a Foley catheter, we used to have to test out the balloon. We no longer do that anymore. We just, you know, connect the syringe, you know, go on with our technique and insert it, and then we inflate the balloon once it's inside. But prior to, like I said, about 15 years ago, because the evidence advised us to check that balloon to ensure that we actually got, you know, set up our Sterifield, we connected the syringe, we inserted the solution, and we made sure that the balloon would stay inflated. Now we no longer do that. So processes, they're meant to change for the better. And so even though we're talking about accountable care organizations, PPOs, HMOs, Medicare, Medicaid, they just really want the best for the people that are subscribing to their services. They don't want waste. You know, they don't want to be using unnecessary products and charges. And of course not, you know, anything that's actually fraudulent. So that's why it's so important to make sure that we're documenting and capturing everything so that, you know, if they come back and ask a question, well, let me see the documentation that supports why this code was actually submitted for this patient, then it's there in the charts because we've documented everything and we followed up the documentation as we should. All right, let's go ahead and pull up the PowerPoints here. We're going to come back to finance, and we're going to go ahead and look at these theories, and I will just come back. All right, so I'm going to take turns, you all, and please let me hear your voices. One person at a time. I want you to just kind of read us through the slides. We'll pause and take notes and ask questions about what's on the slide. So I'm going to share my screen, but I do want to hear from you that you read the slide. Slide show. Okay, so first person, just talk us through this slide. You can read word for word, and then I'll come back and put in any extra information if needed.
You said we could just read it. You said we could just read it off.
Mm-hmm.
Oh, okay. The National League of Nursing aims to lead in setting standards that advance excellence in nursing education. This goal applies to all levels of nursing education from LP to LB to doctoral programs. The organization develops models and competence to guide nursing education, NLN's focus is on meeting the needs of nursing education and advancing national health.
So we have all these governing bodies, and the whole thing is to provide the best care we can for whomever we're going to take care of. And so I don't know if you ever thought about, like, why does this class meet for 50 minutes? Why does this class meet for 160 minutes? Why do I have to have, when I'm taking this class, so many clinical hours? Why do I have to have preceptor hours? So many simulation hours? Well, the National League of Nursing, what they've done, they've set these standards. They've done the research, and they're saying that these are the requirements to gain understanding for whatever the class is. Hence, you have the different time frames. Like, I think geriatrics, we only meet for maybe 65 minutes or so. And then we have clinicals, we might have to have 4 weeks of clinicals. So they set these standards. And then that's the reason why we have the different times and everything, because they're saying, based on the evidence, if we are engaged with the content, with the simulation labs, with the actual real taking care of a person, then we should be able to deliver excellence in the care that we're providing for our patients. Okay, next person.
Official government agencies focus on disease prevention and wellness and are appropriate for PNs interested in community-based services.
Okay, so we have a variety of settings that we can work in, but the whole idea is if we can prevent a disease process from ever happening, and if we can promote that wellness, for example, just, if the fluids are not contraindicated, or they're not restricted, during the summertime, during the winter months, you see these campaigns, stay hydrated. You see campaigns about various things. So the official government agencies, they really want to focus on prevention. We know, based on environment, there's so many things that put us at risk, genetics and so forth. No matter how we try to prevent some things will still occur. But still, their focus is on disease prevention and wellness if possible. Okay? Next person.
Rationale for theories. Numerous nursing theories have been developed for nursing. Some of them are basis for curriculum development. 3 concepts important to nursing: person, health, and environment.
Okay. So these, and we're going to go with a few theorists. There are a whole bunch more out there. But the concepts that they were keeping in mind as the persons were creating these theories, they were thinking about, well, who's going to receive this care? Or this is an adult? Is this person going to be in the home environment? Are they going to be in acute care setting? And then what's that goal for that health? Do we want the patient back to the optimal level? Do we want them to, is our goal in prevention? So this is like the rationale and the 3 concepts they look at when they were creating these theories. So we're going to look at a few of them here. All right, next person.
Florence
Nightingale. Okay, you go ahead. No.
I'm sorry, you go ahead.
Okay, I'll go. Florence Nightingale, first nursing theorist. Florence Nightingale was the first to emphasize the environment, ventilation, warmth, noise, light, and cleanliness, often spoke of as the first nursing theorist. Nightingale felt strongly that environmental issues influence the course of illness.
Who would have ever thought of you? And of course, they didn't even think about this. Cleanliness, the noise. How would that affect someone's healing process? Washing our hands, making sure that the noise is to a minimal. Who would ever thought about that? Florence Nightingale did, and as a result of it, here we are today. Soon you all will be getting your lamps. You'll be getting your lamps pretty soon. All right, let's look at Maslow. Someone read.
Abraham Maslow, human needs theory. Theory states that certain internal, external, physical, and physiological needs are common to all people. Common needs are arranged in a hierarchy. Unmet needs create tension, which motivates the person to react to meet the need. When needs are met, the person is no longer aware of the need, and the need now met no longer motivates him or her. Dominant needs that matter to a person can vary in life.
Okay, so remember the triangle. You would think we need to start at the top, but the way Mr. Maslow had it set up, the bottom. If we didn't have food, water, shelter, if those things were not met, the rest of the things on the triangle were not important right now. And of course, we can go up and down that triangle. Unmet needs creates tension. Let's just say, for example, a storm comes through. It destroys homes. And so right then, before the storm, shelter wasn't an issue. After the storm, there's an unmet need. The person needs shelter. So that motivates that person to find shelter, whether it be a shelter, family member, hotel, contact the insurance company, however it is. But Maslow says, hey, if these things on the bottom, they're more important than the other, but we still know, we do know once those things are met, the person does move up the triangle. All right, next person, Orem. Dorothea Orem.
Dorothea Orem self-care. Wait, we can read it more than once. What matter?
Go ahead.
Oh no, Rose, go ahead if you didn't read. Go ahead, because I really don't.
No problem. Okay, so Dorothea Orem self-care deficit theory is a general theory that has three sub-theories. Self-care, which its goal is directly toward a safer environment for life, health, and well-being. Self-care deficit, personal care does not meet therapeutic self-care demands. Nursing system, nurses empowers the client through their interpersonal relationship to help meet their self-care demands.
Okay. So for the most part, a person wants to take care of themselves. But there are some times when we can just not meet that need to provide the care that we need. If a person has a broken arm, they may have limitations, especially if it's a dominant arm and they're not ambidextrous, then that broken arm will limit that person from being able to feed themselves, bathe themselves, and so forth. And so that nursing system, that's what we step in at. The unlicensed personnel, the PCT, and all of that, we provide the care, the assistance that's needed. One person, two persons assistance, whether or not it's set up help. And we interact with that person. We establish those therapeutic relationships. We empower them to accept the care that we're providing, and also think about the others that are on the healthcare team that will come in to assist that patient in hopes of that patient reaching their optimal level, which was their norm, that person taking care of themselves. So think about, we would need physical therapy, might need occupational therapy to work with that person. Okay. All right. Magdalene Leninger's cultural care theory.
Madeline Leninger culture care theory identified two kinds of care in every culture. Generic, meaning home remedies used in care, professional care provided by people who are specifically trained to provide care. Leninger proposed three modes to guide nursing decisions when providing care: cultural care, preservation or maintenance, culture care accommodation or negotiation, culture care repatterning or restructuring.
So for the home remedies, for the most part, if it does not cause the patient any harm, or the caregiver, the nurse, the PCT that's taking care of them any harm, doctors will write orders to include that in their care. On the other hand, if the whatever the act is that the patient is doing, if it's harmful to them, then that's what we provide, the repattern or restructuring. For example, if they're big on asking, do you smoke? And then if you say yes, they provide you with the smoke-free literature, the programs, they offer you the different medications to try to prevent the from smoking or choosing not to smoke. So that's that repatterning or restructuring. But We have seen it many a times where, for example, if a patient wants like a certain person of faith, they may choose to not accept pain medication, even though, they're in pain, they voice are in pain, and they just refuse it because whatever their beliefs are, and what's important to them, they just would decide to refuse it. And, we just want to make sure that they know that this medication is there for them, but we're going to support them in that informed decision that they're going to make to refuse that medication. Leeches, haven't seen that very much here lately. You'll see different practices, home remedies, but people, they say, hey, it works. And it does seem like some of those things do work. As long as we can make sure that it's not causing them any harm, we preserve that. And that's added to their care plan as their intervention. All right. Hildegard Papler, interpersonal relations theory. Someone read for us.
Hildegard Papler's interpersonal relations theories, a basis for developing a therapeutic relationship with the client. The relationship that is developed has certain parameters and is the major part of the treatment. Papler describes 4 overlapping phases. Orientation seeks assistance because of a felt need. Identification understands the situation and responds. Exploitation begins to depend on the nurse and uses the help offered. Resolution, dependent behavior must now be given up as the therapeutic relationship ends.
So, and sometimes of course, it's important to establish that therapeutic relationship because we want that buy-in from that patient to open up, and tell us about what their values, what they deem important, and also the things that they understand about the disease process. And then once that orientation, they begin to understand the situation, they begin to come around and respond. And then you will see them ask you more questions and be more forthcoming with information, whether or not it's good, bad, or ugly. And then once they get that understanding and get those tools that they need to be able to manage their care, then they clip our wings. They say, hey, I got it from here. I understand how to do my finger sticks. I understand the sliding scale. I understand this home blood pressure monitoring. I understand if it's this numbers, I need to call the doctor. Those are just some examples. And so you do want to see that. All right, Rosenstock's health belief theory. Someone else.
Tries to explain why a person will or won't take action to prevent or detect illness. Precipitations vary and may have no basis in reality. Beliefs are connected to existing barriers. A cue to action is seen as necessary.
So their perceptions may vary. It just depends on, what they deem, what they believe, like belief. Rosenstock says, depends on what this person believes. What are their perceptions of what's going on? Do they understand or believe that taking this medication is going to benefit them? And if they don't think so, then their action will be non-compliance. But we do want to make sure that our patients have enough information so they can make an informed decision. Okay. All right. Sister Callista Roy's adaptation model. Someone read for us.
Describes the recipient of care, the client, as a holistic adaptive system. Both internal and external stimuli affect the system. Identifies the type of stimuli as focal, referring to something direct, such as a client experiencing pain. Contextual, meaning other factors that affect the focal stimuli, like being examined in the area of pain. Residual, referring to both internal and external factors that may not always be evident. Coping mechanisms, regulator subsystem, refers to the internal effects that take place in response to what is happening internally. Help me pronounce this pretty, please, Dr. Ford.
Cognator, that's what I say.
Okay, cognator system, subsystem.
Mm-hmm.
Subsystem refers to learning, processing, judging, and emotion that the client uses to cope with what has happened.
So we're looking at Thank you, ma'am. We're looking at the entire person. We're not just focused on, we have a patient in room 201 that I have to go down here and check their blood pressure. We're also, Sister Callista says, hey, we need to think about everything, the good, bad, the ugly, this whole person. And see what, not only see what they understand, but bring that into the care plan. You know, sit down and talk with them, understand, gain understanding of what they know, but not only just focus on that disease process, but also their environment. You know, once they leave the hospital and they're going to receive these home health services, you know, is the home, is it doable? You know, is it livable? Do they need some repairs? When they go home, do they need this medical equipment? They may need a cane walker or crutch. Do they already have this? We want to look at the entire person. Do we need to bring in or set the person up to go to the wellness center? Does this person, do they need a different level of care? This person was initially in the assisted living facility. Now they may need care, more care. So do they need to be in a SNF, you know, skilled nursing facility, or do they need sitters in the home? You know, do they need meals on wheels? You know, they're able to manage their care at home, but then they need someone, or they need assistance with cooking. So do we need to set up Meals on Wheels so this person can go back to their home and be as independent as possible? But nevertheless, looking at the entire person, how they cope, the internal factors, you know, what is their understanding, the outside factors and everything. All right, next person.
The
The
Joint
Joint Commission
Commission.
is an independent, not-for-profit organization that develops and applies standards for quality and safety in healthcare organization. It conducts on-site surveys, evaluate actual care process, and helps healthcare staff improve their performance. The Joint Commission is also recognized an accreditor for CMS, Medicare certification, and accreditation. Is seen as a national symbol of healthcare quality.
So usually you see this in the acute care settings. And usually when we were there, you know, doing our rotations, our clinicals, when JACO came in, the Joint Commission came in, we had to leave there. So, because it's a big to do. And all of these regulatory agencies, for the most part, they're nonprofit. And they want to just ensure that we're providing that excellent care. Remember the NON, the National League of Nursing, the whole point of you sitting in this class a certain time, you having this number of clinical hours and all of this is so that we can be excellent in what we do. So the Joint Commission says, hey, you have these people that have been certified, they have their license, and we're talking about everybody. The doctors, they look at everything. They go through those records. They actually look at the processes. You know, for example, if the facility has if they have on-site sterilization, when they come in, they go and look at the process from the beginning to the end, just to ensure they pull out that policy and procedure and they look at the process, they compare what they're seeing. Now, the Joint Commission goes into the hospital settings, and we do have in the long-term care settings, they do have a survey process where the state comes in. And then in varying states, they call them different things, but nevertheless, is a not-for-profit organization that comes in and ensures that appropriate care is being delivered in these healthcare facilities. And the other thing is Medicare says, hey, if you are a facility that you're submitting charges and we are reimbursing you, guess what? You got to let Joint Commission come in. You have to let these governing bodies come in to see, because that helps us to ensure that, you know, this patient may have had a bad outcome, but it's not because the facility didn't have appropriate supplies. The staff wasn't trained and didn't know what they were doing. Because when these governing bodies come in, they check us out or they ding us and say, hey, you know, we got some things going on. They can fine you, they can shut you down and all of that. All right, James Watson's theory of human care.
Health is harmony among the body, mind, and spirit. Involves self-perception and how the self is experienced. Illness is lack of harmony within the self and the soul. Nursing role is a caring process to help the client regain harmony and health.
Exactly, doing that reteaching, establishing those therapeutic relationships, being assertive, being honest. And then if it's a client, I gave early on the example where the patient signed off the consent and said, hey, I just signed that consent off because that doctor was in here, but they're confiding in you. And that nurse getting that doctor, the healthcare provider, to come back in and explain that procedure to that person so they can make an informed decision. And so, again, we're looking at the patient, we're kind of considering the whole person, and moving forward with providing that best care that we can. All right, next person, nursing research.
Identify specific nursing interventions that are proven effective and not merely based on tradition. Provide evidence that supports the quality and cost effectiveness of what nurses do. And generate knowledge for clinical practice, nursing education, and delivery of nursing services.
So we're not just pulling interventions out of the air. It is specifically based on what the evidence says that we should be doing. At a minimum, we're turning and reposition people that needs assistance every 2 hours at a minimum, because the evidence has shown that this is what we can do. This is one thing that we can do to lessen the chance of someone getting a pressure ulcer. And so it's evidence that's guiding what we do. Remember the example I just told you all about prior to maybe 15, 20 years ago? We were, once we set up our sterile field for the Foley catheter, we were connecting the syringe and we were actually inflating that balloon to ensure to see that that balloon stayed inflated. Now we no longer do that because the evidence says we don't need to do that. So processes will change over time. Policies and procedures, they should improve so that we can provide that best care for our clients. So we're talking about research. So we see quantitative. So quantitative, someone read this one. Quantitative versus qualitative.
Quantitative research studies, objective study a variable. A variable is the event that researchers is trying to measure. Two types of variables. One variable is the group of receiving the intervention. The other variable is the group that does not receive the intervention. Randomizing control trial recommended type of quantitative research.
Okay. So with this research, we're gathering some type of data, whether or not it's heights, weights, whether or not it's blood cell counts, whether or not it's lipid panel, cholesterol, total cholesterols, whether or not it's an echocardiogram. We see what the heart function is. Nevertheless, we're getting some type of quantity information. And so you do have the one group that's receiving whatever the intervention is, and the other group considered as the variable group or the control group that does not receive the intervention. And then you make the comparison. But quantitative, we're getting some type of data from this type of research. Then we have qualitative research. Someone read for us.
Subject study. Data are gathered by interviews and study is a narrative. Description of the lived experience of individuals, for example, living with chronic pain.
Pneumonology.
Yeah.
Pneumonology. I know it's a mouthful, right?
Okay. Is an occurrence of circumstances that a researcher studies. A case study examining the lived experiences of high school students who are both gifted and diagnosed with attention deficit attention disorder, ADHD.
So with qualitative, you're still gathering information. It is not a blood pressure measurement. It's not a height. It's not a red blood cell count. It is that person's lived experience. So this can happen via one-on-one. It could be via Zoom. It could be an in-person interview. It could be via a survey. Survey can be electronic or paper and pencil. But with qualitative, we're still gathering data, but it's information that we're getting from that person's experience as they have lived. So an example would be, excuse me, we did a focus group with people that had been diagnosed with diabetes. And and so you have this set of questions. You just, you don't just come up out of the air with questions, but they have a set focus questions. And we'll talk about the PCOT and all of that here in a minute. And you ask those questions and they just volunteer and just tell you there's no wrong answer. So you get their lived experience from whatever that information that you're trying to get. For example, the diabetes, how do you think that your insurance company provided resources to help you manage it? And if so, what were those resources? You just ask questions like that. But it comes from a conversation, whether or not it's face to face, Zoom, in person, via some type of electronic meeting and or a survey, that you get that person's lived experience versus quantity. You get a measurement of something. All right. So Cochrane, evidence-based practice. Let's look at Dr. Archie Cochrane.
Dr. Archie Cochrane, a British, oh, go ahead, whoever wanted to read.
Dr. Archie Cochrane, 1901, 1988, a British epidemiologist, challenged the public to pay only for medical care that was proven to be effective. He advocated for the use of randomized controlled trials, RTC, as a means to reliable informing healthcare practices. The Cochrane collaboration was established to prepare and promote the accessibility of Cochrane Review, a collection of evidence-based healthcare interventions obtained by systematic reviews of research.
Okay, so Cochrane, looks like two things stand out to me: evidence-based and systematic reviews. So we're just not pulling strings out the air, just making up interventions. He says, hey, if the evidence does not support why a facility has created this policy and procedure, why they're doing what they're doing in their facility, excuse me, then we're not going to pay for that care. So hence, when you're writing your papers, you created your project, and you've heard use the last 5 years, evidence-based practice. Dr. Archie says, hey, this is important, that we're just not haphazardly pulling things out of the air. Now, they do have a process that if someone comes up with some new technique, there's a process that we go through to test it out to see if it works, to create more evidence, new evidence. And so the Cochrane collaboration says, hey, it needs to be evidence-based healthcare interventions. And how are we getting that information? We're getting it through systematic reviews of research. So those are the two things that stand out for Cochrane. So I read this one. Evidence-based practice continued. 1999, the Institute of Medicine issued the report To Err is Human, Building a Safer Health System, which discussed the incidence of medical errors in healthcare and the need for reform. In 2001, the Institute of Medicine issued Crossing the Quality Chasm, a new health system for the 21st century, calling for a consistent, high-quality healthcare for all people. Included was patients should receive care based on the best available scientific knowledge. Why are we doing what we're doing? Because the evidence, the scientific information, whether they come from qualitative or quantitative information, that's why we're doing what we're doing. So during the last 2 decades, insurance companies began to pay for healthcare practices only if their effectiveness is supported by scientific evidence. So what that means is they will look at the facility's policies and procedures. If it doesn't match what the latest evidence is showing, they can decide not to submit reimbursement. So during the last decade, hospitals are denied payment when complications in a Medicare client is developed if evidence-based guidelines are not followed. How do they know? Look at the documentation. The documentation via written nurses' notes, doctor's progress notes. They look at the labs that were ordered, the medications that were administered. They say, hey, either you did or did not follow the procedure, the evidence-based guidelines. And if you don't follow the evidence-based guidelines, which comes directly from your documentation, they say, hey, we're not going to pay you. We will not reimburse you. So clients and families are seeking the latest evidence on websites about the most effective treatment in illnesses and diseases. All right, someone read this one for us.
The clinical question being investigated is formulated in an objective, constant manner. Using professional resources, the latest, most relevant research evidence that pertains to the clinical question is located. An expert or panel of experts conducts a systematic review, which is a summary of the results of the selected studies. Guidelines are determined. Using critical thinking skills, the gathered evidence is combined with clinical experience and the client preferences and values for use in a specific clinical situation.
Evidence, systematic review. Okay. So elements of evidence-based practice: best research evidence, nurses' clinical expertise, and client preferences. These three things are essential. You need to know best research evidence. These are the elements of evidence-based practice. The client preferences. We want to consider what they, because they're the ones that's receiving the care. So we want to know, what do they prefer? Our expertise, the nurse's clinical expertise, and then the best research evidence that we're providing, the latest evidence, interventions for the patient. Okay, so this slide just shows all the different nurses' roles. Okay, and then the practical vocational nurses' role in evidence-based practice. Question the basis for nursing actions. We go into facility, know why you're doing. It's okay to ask why you're doing it this way. Why is this process this way? Excuse me. Review current articles. So remember, as healthcare professionals, we are life learners. We are all the time increasing what we know. We're trying to find out what's the latest information. So we do these at least a yearly check, and then going forward, the things that we find that we want to find out new knowledge on, or we need to update our existing knowledge going forward, those are the webinars, those are the conferences that you attend, so that you can gain that latest evidence information. And as far as your nursing license, a requirement for mostly all nursing license, one requirement for renewal is that you have so many hours of this new evidence, this new information. Okay. So the spirit of inquiry, usually you see it in the new nurses because you all have the latest information. You just written papers, you're doing a group project. So you all really have the latest information the last 5 years. And so spirit of inquiry is not a bad thing. It is where we ask those questions to seek to determine if there is a different way of doing the process so that we can have better outcomes for our patients, so we can use less supplies, so that we can be more timely with our technique. Now, some procedures, it is what it is, but there are some times, but we still want to raise that question to see if, because if a patient can have better outcomes, who wouldn't want to do the new process? So that's that spirit of inquiry. All right, so any questions about the content we just covered? So, you all, for your project, you have to go back and look at the latest 5 years of information. And, usually those are, we ask you to look at peer review information. And so, because we want to incorporate, remember those three things: the nursing expertise, the client preferences, and then the latest guidelines into that patient's care. So while we're collaborating with that registered nurse, coming up with the goals and the interventions, these are things that we need to keep in mind. Excuse me, wow. And so, wow, that took some time for you all to read through and get your resources. You had to do the evidence, because when you're like looking up concepts, there's all this information out there. But then some of the information is not about what, not about what you're looking for. For example, you all were assigned certain topics. So when you typed in whatever, all these things popped up. So a barrier for implementing evidence-based practice that we have found constant is like, hey, we just don't have time to look for the latest evidence. So that's why facilities have come up with these committees, and with these committees, they have the time. They're given the time. It's worked into their schedule where they can do the research and bring the latest information to us. Because what we have seen is that we just don't have time. We just need to go take care of our patients. We don't have time to do the research. So that's why they've come up with these extra committees. All right, so let's just go back and we're gonna toggle back and just start reviewing here. I don't think this is the slide I want to go to, but we'll go through. So remember, I initially asked you all create, design this perfect healthcare system. We came up with all these ideas, and that's how you know, as time has evolved, the governmental agencies, just in the politicians, policymakers, they've done these things. They've done the research. They looked at what the theorists were saying, and they tried to create these systems. The managed care organizations provide for both the delivery and financing of healthcare members. You know, they have the HMOs, the PPOs. You know, one doesn't cost that much, but then, you know, there's some limitations. You need a referral. So we talked about that. Managed care aims to reduce excessive and unnecessary costs. So that's what they're thinking about. The bigger picture is how can we provide that best care without spending so much money? You know, are these tests really needed? Do we need people to be retaught? And so providers receive that lump sum per patient for the set of services that they provide. And if the charges exceed what that lump sum is, then the facilities or the patient, they have to pay the remainder. So this approach can motivate payers to control costs, because think about it, if you own a hospital and you're getting this lump sum from this insurance company, and you know this is all you're going to get. So you do want to make sure that your staff is well informed, that not only that they're informed, but they can actually perform. Like if they have certain procedures, new equipment, we want to make sure that our staff, they know how to use it. What is it for? Because otherwise you're going to lead to either people that equipment not being utilized, and then we're going to lead to probably decrease in patient care. So concerns arose about compromised quality and constraints on patients' choice. So that was the thing about the managed care. The MCO was like, hey, you know, did we really consider what the patient wanted with this? And that's why you have to just pick and choose what insurance companies that you want. We kind of talked about that pretty good. The private insurance companies, we said, hey, once they came on the scene, the healthcare costs, you all, they skyrocketed. They really did. We talked about Medicare, Medicaid, Veterans Health Administration. Those are the public health insurances. We talked about Medicare. Went over that pretty good. Talked about they encouraged, Affordable Care Act encouraged, did we get to that one? Yes, encouraged the employers to offer it to the employees. We talked about that. Okay. The patient meets the income and asset requirements, they may be eligible for both Medicare and Medicaid. There are some people that are 65 and older, but then that income qualifies them for Medicaid as well. So they are dual eligible. So they can, in fact, subscribe to both Medicare and Medicaid. If a person, even if they are less than 65, they have one of those qualifying conditions that qualifies them for Medicare, and then their income is such that they qualify for Medicaid, they can have both of those. This could provide additional coverage and financial assistance for the person's healthcare needs. We talked about CHIP, those well children checks, the well child visits, preventative care. It is still, it's still required for them to get those. Those are not exempt. CHIP is just how we pay for those services. It does not mean that they get subpar or less than the best healthcare. So private insurances, like I just said, while designed to make healthcare more affordable, has contributed to those rising healthcare costs. And insurance made healthcare more accessible. It increased the demand for services also. So that's why they keep saying that we have these shortages of all the healthcare providers, especially the specialists. You know, some specialists, you have to travel miles and miles to actually see them because the demand is there. With the advances in technology, with the advances in the evidence-based information, people are living longer. They're being able to manage their disease processes. And so there's that increased demand for services. We talked about the value-based purchasing program. It looked at the care measures. the urinary tract infection, falls. Pressure ulcers is another one, you all. So if a person came into a facility, it is not automatic that they should leave there with a pressure ulcer. They did not have one when they came in. So that value-based purchasing system would say, hey, this person wasn't really taken care of, because it's not automatic that they end up with a pressure ulcer or that they fall or end up with a urinary tract infection. We talked about ACOs. They're groups of healthcare providers that coordinate high quality, cost effective care for Medicare patients, especially in primary care. Their goal is to improve those outcomes while reducing unnecessary spending. Still, they're still saying the same thing. We want the best care for our patients, but we don't want you just spending money just because you can. We don't need you submitting all these charges if they're really not necessary. To achieve this, the ACO must promote evidence-based practices. Going back to Cochrane, remember Dr. Cochrane said we need systematic reviews and evidence-based information and interventions. So ACOs, they look at these reports. They come in, they look at your reports. DRGs, remember, they look at it's diagnosis related. If a person comes in and is written down that they have, are getting the knee replaced. So based on that diagnosis, they've done all the pre-work. They've looked at the evidence. They pretty much know how many sponges, how many follow-up visits. They've done all of that part, and they submit reimbursement based on that diagnosis that was submitted. Okay. So HMOs, we're going to take a break here in just a second. HMOs typically have more limited network of providers and require referrals for specialists. We've already said this. PPOs usually offer a larger network and don't require referrals for specialists. And then HMOs often have those lower premiums and out-of-pocket costs, but they have that less flexibility because they require those referrals. PPOs generally provide more flexibility, including the option to see out of network providers. So we're going to stop right here. We're going to pause and take another break. So we will see you. We don't really have that much time, but we're going to still take your 5-minute break, you all. We'll see you in 6:39, 6:59, 6:39. You all, I don't know what's going on me with these numbers. So 7:39. Eastern Standard Time, 7:39. See you in 5. Just a reminder, this recording still plays, you all, so make sure you're on mute and turn your cameras off. All right, you all come on back. Okay, so we're talking about this continuous quality improvement. And so ACO, MCO, PPOs, all those things, they want that. And so a lot of facilities do have quality improvement committee. So this is an additional task that you can work on in a facility. And know that you will be identifying processes. Like I gave the example earlier, I said, they look at the number of falls. They look at the number of call-ins or turnovers. They just look at everything from A to Z to see, can we improve our process? Then we have the Institute of Medicine. They were focused on improving quality in healthcare as well. So they came up with this STEEP. Let's go over here to this slide. STEEP. We're gonna come back to that. So we need to know STEEP. STEEP stands for safe, avoid injuries to clients from the care that is intended to help them. So, clients shouldn't be getting injured from us administering medications. So, in order to prevent that injury, we need to make sure we're administering medications according to the medication administration rights, ensuring that we're identifying who this person is that we are actually giving these medications to. So we want to keep the patient safe. We want to make sure that we're giving care in a timely manner. You've probably even seen some billboards or some commercials where they actually advertise, hey, our wait times are this. And so, in fact, if someone comes in for an issue that needs to be addressed pretty quickly, that's not safe for that patient to sit there and wait 30 minutes and hours to receive that care. Something that comes to mind, chest pain. People that come in with chest pain, we move them back pretty quickly. Facilities also, I know in a bunch of ERs, we have seen where they create like different tracks. So if a person comes in initially and it seems like they're not going to be admitted, they go this pathway, for example. And so it's not making them wait behind all the others that are needing this immediate care, but we are still seeing, we're addressing what they need, but they're not in this line waiting. And so another thing where we see too, where they're being more timely, is if a person presents with whatever their presenting signs and symptoms or complaint is, that they go on and ask those focused questions for that, and they go ahead and move the patients on back to whatever track. Now they come back and still ask all those other questions, but they go ahead and move them on based on that initial complaint. And then based on that conversation, they'll decide, whether or not is this the complaint or if additional information is needed. But nevertheless, they're going to still ask all those other questions. So effective, provide services based on the scientific knowledge. What Cochrane said, we needed evidence-based, scientific knowledge, systematic reviews, that the facilities are not just creating policies and procedures that are not evidence-based. Being efficient. We want to avoid wasting equipment and supplies and the nurses' energy, the team's energy. So we want to make sure that our processes really have been refined. That's where that spirit of inquiry comes in at. Can we complete the same process? Can this patient have better outcomes using less time, less resources, being efficient? And then equitable, provide the care to the patient no matter what. Best care to everybody that comes in, no matter about pay status, gender, doesn't matter. We're going to provide the best care for everyone. And then patient centered, we talk about asking about the client's preferences. What do you value? What is your preference? Because remember, it is them that's receiving the care. So make sure that we're knowing what the acronym, when we have all these different acronyms in healthcare, but STEEP, safe, timely, effective, efficient, equitable, and patient-centered. Okay. I was going to go back to this other slide. So they look at, too, another quality measure that they look at is readmissions. So it is a 30-day. I was thinking it was 28 days, but this slide says 30 days. So another thing that those non-for-profit, those regulatory agencies, that when they come in, they look at the number of people that have been readmitted. Then they look at the time frame from the last admission. And if it's within that 30 days, then those paying sources may say, hey, we're not going to submit you the full payment, because if a person's having to come back in this early after being discharged, we might not have did everything for them that we should have done when they were here the first time. So so they're looking at readmissions is another one of those things that they look at, those core quality measures, and say, hey, yes, you're doing what you need to do. That's why it's so important to document everything, because someone can be readmitted and, they could have had some other things going on. It could be something new. So that documentation is going to be really important. But these pay sources are looking at that 30-day in readmission, and they're just making a decision whether or not to pay a reduced payment or not. Okay, we talked about Joint Commission. So there are some long-term national patient safety goals. These are the ones that we see in the hospitals, where they're looking at the medication error rates, where they're looking at wrong site surgery. People were coming in to have surgery on their right knee and they end up having it on their left knee. So these are the national patient safety goals, where they have, when Joint Commission comes in, they look at the data. They look at, how many people have had surgery? Was it the correct surgery? It's a yes or no box. And then they go and look and decide and look at their processes and see how can we prevent this from happening. Because if a person had a wrong site surgery, it was on the left leg instead of the right leg, that person is still going to have surgery again, right? On the extremity that the surgery was originally supposed to be done on. That increases patient time, fees, and just undue harm to the client. So in long-term care facilities, they look at pressure ulcers, falls, and then also the accuracy of identifying the residents that are there. So how are patients, if you are rotated through long-term care, and if so, how are they how do you know who that patient was, that resident was? Tell us about it.
On their doors, or like if you're passing medication, they have a picture up of
Okay.
the resident.
Exactly. All right. And then, of course, you can always ask name and date of birth, but they have that extra layer. They have pictures of them, and then they have their names on the doors. I haven't seen armbands in those facilities, but I do see inside the rooms, they'll still have on, like, especially if the person is sharing a room, they'll have some other identifying, like their name on something inside the room as well. So we talked about the hospital safety goals, cost containment, all these different entities, these resources, ACOs, PPOs, all of them, they're looking at providing that best care, controlling that cost. And a thing that they've done too is they try to restructure the healthcare system, so they try to see what could they merge, can people work together, these different companies, and then they have like one major hospital will have several other smaller hospitals, just to see if that would help us get through the maze of healthcare, but at the same time getting that best care without any complications. Because it's not foreseeable that the value-based purchasing system says, hey, we don't foresee, it's not an automatic, if a nurse needs to put in a Foley catheter, that client ends up with a urinary tract infection, and if it does, then we're not going to pay. Okay. All right, let's see. Let's look at those other slides that we went over. See if anything else we need to pull out and talk about. So OSHA, what is OSHA? What are they there for?
To make sure the facility is safe and
Exactly.
reading of the biohazardous stuff correctly and all that.
Making sure our workplaces are safe for us to be working in. Exactly. If it's requiring in your facility, if it's you know, if it's a rug is required, wherever it is, and that rug is torn, we need to be reporting that, because if that rug is there for a reason, more than likely keep us from slipping and falling. If it's torn, then we need to report that that rug needs to be replaced. There have been people that went to work and never returned because of, OSHA's everywhere, health facilities and all different facilities. And so the workplace should be safe. We should have PPE in the event that we need them. The facilities are supposed to provide, things that we need so that we can be safe at work. Now, we talked about Food and Drug Administration. Remember, it tells us it oversees foods, medications, and also those medical devices, like stents. Who says that the stents are good for us to insert into people? Who says that the replace knees, the artificial joints, that these things are good to place in people? So the FDA oversees that. They say that these things, and of course, they go through rigorous testing and they have to provide data and all of that. But the FDA, the Food and Drug Administration, oversees foods, medications, and as well as medical devices. Okay, so we talked about these regulatory agencies. The overall arching goal is to protect the public, protect the people that are receiving these services. We talked about J-code. Private health insurances, we said healthcare costs skyrocketed. Home health, the care is rendered in the home. Skilled nursing, you all remember skilled nursing is medically necessary care to improve health or to maintain or slow decompensation. So a person's had surgery, they're needing that physical therapist, that occupational therapist. This person might need IV medications for whatever was going on with them so they can get back to their optimal level, but it's skilled nursing. So hospice versus palliative. Palliative care, a person can subscribe to palliative care at any stage in the disease process. Hospice is usually, it is geared toward when death approaches. And so usually life-saving measures are not chosen here. Now, I've seen people that have subscribed to hospice, they've been deemed as terminal, and they've unsubscribed from hospice. They've come out, their conditions improved, and they no longer need the hospice services. So these are just facilities that we can work in and provide care for patients, residents. They call them different things, depends on, what facility that you're in. We talked about Medicare. Talked about the different parts. Okay. Medigap, remember Medigap steps in it is what it is. Those benefits that the other insurances don't pay for, Medigap stands in the gaps and offers some assistance so that those services can be paid for. That was a good name, Medigap. It stands in the gap. We talked about Medicaid, low income, it's income based. A person can have Medicare and Medicaid. We talked about CHIP. It covers those preventative care and regular checkups. It's expected that they still get those same preventative care and those same well child checks. CHIP is just how those services are paid for. So someone that's underinsured, in the event that a person has to walk up to the doctor's office and pay for that visit out of pocket, it is costly. So more than likely that person will put off, going in to see that doctor. So usually we see those patients in the emergency rooms because we have that act where it was on one of our slides. I'm just going back through our slides from last week, where I want to come back to it. Was it AMLA? Yes, where the hospitals can't turn you away is an act. But prior to that act, it's on one of these slides. Okay, right here, Emergency Medical Treatment and Labor Act. Prior to that, 1986, hospitals could turn people away, but right now they don't. So that's why if someone is underinsured, uninsured, whatever, they go into the hospital, they know that they would not be turned away. So let's look at this OBRA here. Several comprehensive federal budget laws passed over different years. So provisions have addressed nursing home standards, physicians payment reform, but the whole gist of Oprah, you all, is it required a comprehensive resident assessment, those MDSs. So in long-term care facilities, you can work on the MDS team. So it's a comprehensive assessment. It's all the way down to the point of, do the patient need setup help? One person's assistance, two persons assistance while they're walking in the corridor. Do they walk independently? Are they having to hold on to the rail? When they get a bath, are they able to perform it themselves? So OBRA, the Omnibus Budget Reconciliation Act, it required this comprehensive resident assessment, which leads to the minimum data set, where it tells about the care that is needed for the patient. So the quality assessment model. Remember the examples that we gave, we went through these. So the structured example is where the School of Nursing established a nursing managed collaborative where the clinic was provided there for non-insured patients. You know, this example, the patients had diabetes, and so they provided that care for them 2 days a week in the clinic there. The National Quality Forum, a not-for-profit membership-based organization, here it again. And so the whole point of it was instrumental in advancing efforts to improve quality through performance measurements and public reporting. So again, they want to come in and see. When you go to the hospitals and the long-term care facilities, it should be readily available what their scores are. So that's that public reporting. And so the facilities have to display that and show how they perform on those standards. There's a central repository for healthcare measures that are considered scientifically sound, have been standardized for use across facilities. So they've got these set of standards and say, hey, this is what we should be performing. This is how we should be performing in these facilities. The expectation is no pressure ulcers if the person did not come in with one, because we have to identify interventions that needs to be implemented so this person will not get a pressure ulcer. It's not an automatic that because a person requires assistance that they will automatically need end up with a pressure ulcer. We talked about professional development. It's a continual review. It's continuous. While we have these breaks, where you'll get your 6-month review or your yearly review, but it's a continuous thing. It's continuous. I want to go back to talked about that. So healthcare policies, decisions are made by authorized government institutions such as legislators or courts, or by governments that are authorized entities. And they make these decisions and they create these policies for the greater good. So this is why, for example, something that was out here where the school, the exams that the athletes need, the policy says in a lot of states that they have to be signed off on. The nurse practitioners can complete the exams, but they must have that final review by that MD. And so that's the reason that we're doing it, is because the policy says this is how it should be done. So the policy, the legislators, they go through and try to gather the evidence and information to create good policies. We went over this, and we'll go over it again. We have about 2 minutes left, y'all. We just recapping information. So plan, do, study, and act. Question: the team that we're working on, we get to the study stage, and we say, hey, we need to go back to the planning stage. Can we do that? Or should we just keep on going to the next stage? Can we go back and forth within this cycle?
Yes.
Yeah.
Yes, we can. Yes, we can. Because sometimes once you get on over here to the do stage, you be like, wait a minute, this is really not the issue. We need to go back and gather some more data. You can make it to the study stage and decide, well, hey, we need to go back. So yes, you can go back and forth. during the plan, do, study, and act cycle. You can go back and forth. Okay. So the PCOT question, patient population, who and what the question is about. You know, we are getting ready to do a qualitative study on people with diabetes and the self-care measures, the intervention. You know, what is the intervention? We're going to do a survey. Describe the alternate intervention. We're not going to give the survey to the other group because remember, we got to have that control group. And then the outcome, we're going to define the important outcomes, beneficial or harmful. So the outcome would be, hey, we will establish and create or come up with at least 5, mechanisms or things that people use to manage their care. And then over what time frame will we be asking these questions? Will it be 6 weeks? Will it be a month? And that's just an example I gave. But we do need to know the P, what these letters stand for. Patient or population, the intervention, the compared intervention. So that's all together. Then the outcome, and then the time. So the compare, we're not going to offer that intervention to a set of our patients. All right. And so we'll come down to the end. We reviewed everything we reviewed and re-reviewed. Are there any questions? All right. So exam 3 is on next week. Be sure to the exams. Remember, you all are available at least an hour prior to class time. Go ahead and make sure you download those things because with the connectivity going round and round, like it is, we don't want you to come into the exam and it's an issue because you can't download the exam. That's just unneeded stress. So make sure you download that exam, have your 2 devices, your chargers, your identification. If you want the exam proctor, we need a proctor, an approved proctor, and that the campus dean approves that. Send an email with those person's name in there, Dean Brown and myself, with the date and time and all the logistics about when and where you're going to take this exam at. You all take care, and we'll see you all next week.
Quick question. Do you see the questions?
I don't. I see the content as you do. Hey, you all remember, go back to our classroom recordings. And
I couldn't remember or not if you could. That's crazy. I'm going to ask Dean K because somebody could be able to see them exam questions.
I think y'all should be able to see
that wouldn't be fair for us to look at the questions and then teach.
I mean, all my other class, the teachers see the exam so they make sure
that I don't think that's
it's true. Oh well,
I don't know. But I know we
don't
have these
tell what another.
That's why I just said never mind.
Because we are being recorded, so that's why I said just some of these conversations.
I'm hanging up. I'm hanging up. Bye bye.
Bye. Yeah, some things you all just watch what you said and where you at. I mean,
okay.
Stop it.
Let's go. I just got a quick question, real quick.
Wait a minute. Let me pause this recording.
Oh yeah, you